Thank you. And thank you for the opportunity to tell you a little bit about our work. So in the past, treatments for cancer have often been based on where the cancer arises. However, with new techniques, new molecular techniques, it's become obvious that each cancer actually has many different subtypes, and each subtype may require a different therapy. And really, we need to understand the molecular drivers of each subtype to be able to optimise treatment. Now, I've put up this fairly complicated slide to illustrate this with the cancer that's of great interest to us, which is ovarian cancer. So ovarian cancer, along the top there, you can see, just looking down the microscope, you can see that they're different subtypes. Then when you look at the mutations that underlie what looks different, you can see that there's different molecular drivers. In other words, different mutations that occur within those cancer types. But even in cases where they have the same mutations, they can have different expression subtypes. So as you can see, it's a really very complicated landscape, and so we shouldn't be surprised that all of these different cancer types don't respond equally to standard treatment. But luckily, in understanding these different molecular features, we're seeing changes that are actually new treatment targets that could be indicating different treatments that we could use in ovarian cancer. So what we want to do is move from what we can see here as conventional care, where the patients are different but receive the same treatment, but only a proportion will respond, to a situation where we do some form of molecular pathology, understand the differences, and then treat the patients according to that with different therapy. Now, while that's very easy to say, and really one of the themes of today's conference in terms of the right treatment for the right patient at the right time, very easy for me to draw that cartoon, but it's very difficult to do this in practice. I could spend the rest of the afternoon telling you about the challenges, but I've just listed a few of them here. Firstly, what tests do we do? Does the treatment actually work in that treatment, for that treatment target in that cancer type? We need clinical trials to answer those questions. But in fact, doing the clinical trials, as we've heard this morning, can be very challenging. For instance, if we wanted to do a clinical trial, to address the two little green ladies there, we would have to screen a large number of patients just to identify those few patients that might be suitable for that trial. And what we're finding is that causes great patient disappointment. So these patients get very invested in being part of a clinical trial, and when they're told that they don't have the right cancer type, that leads to great patient disappointment and also a waste of time for the patient, so time that they could have been spending on a more suitable trial. So it's really a very complicated scenario. So to try to address some of these challenges, we've introduced a program in New South Wales that we've called INOVATE, or Individualised Ovarian Cancer Treatment through the Integration of Molecular Pathology into Multidisciplinary Care, or INOVATE for short. So in this scenario, what we're doing is all patients, ovarian cancer patients, are eligible for recruitment. So far we've recruited 288 patients from across 10 sites in New South Wales. All of those patients undergo very intensive molecular testing, and if they relapse and need that information, we are armed with that information to know which clinical trial to put those patients on. We're investigating a number of different ways of delivering this very complex information back to the clinicians through reports, through molecular MDTs. But one of the cool things that we're working on, what we've done is introduced a molecular data portal so that the clinicians can log on, see the study overall, but they can drill down and look at individual patients, individual patient mutation data. The portal will tell them what drugs would be suitable for this patient, what clinical trials might be available, etc. So how are we going? So the study's still fairly new, so most of our patients have not yet relapsed, but of those that have progressed, we've had a number on clinical trials and a number for which we've found changes that would make them suitable for a clinical trial. And I'm just going to take you through a couple of examples just to illustrate that. So here, I've got two what we call CA125 plots. So CA125 is a blood test. In the top, you can see a historical patient. So the dotted line is normal. So that patient has a very, very rare type of ovarian cancer with a BRAF mutation. In that case, she's been treated with standard chemotherapy. What you can see is that she's had no response at all to that treatment and has died in less than a year. That's to be contrasted with the bottom, one of our INOVATe patients who was identical to the top patient, didn't respond to treatment, got put on a BRAF inhibitor, and has had a fantastic response and is still alive 3 years later. So an illustration there of the past and the future. We have another marker that we've been testing, cyclin E. So amplified cyclin E, we showed some years ago, is associated with a very poor survival up on that Kaplan-Meier curve. We've identified patients with amplified cyclin E and now have a number of those patients on a clinical trial. Our clinicians have come to us, said we've got a new immunotherapy trial targeting mesothelin. Can you tell us who to put onto that trial? And we've been able to indicate who doesn't have it and who does have that marker. Of course, we haven't managed to get every single patient onto a trial yet. Some have progressed or for other reasons have been ineligible, but certainly that's our target. So, in conclusion, ovarian cancer, really, there's a range of molecular changes that underlie this disease. We really need to, optimising treatment will require a diversity of approaches, but we think that this method of pre-screening the patients at diagnosis will give us a chance to be able to make sure that they go on to those appropriate clinical trials and ultimately improve outcome. Thank you. And I'd lastly like to thank, of course, a study like this requires a lot of funding, and we have that funding from the Cancer Institute in New South Wales, and it requires input from a huge number of people, some of which are here in the room, so I'd like to thank those. But of course, the main people we'd like to thank are our patients, because they have been absolutely fantastic in being involved in this project. Thank you.
Thank you very much, Anna. Does anybody have any questions for Anna? We've got a lively crowd today. Okay, it's a good job I've got some in my back pocket. I was wondering just about the challenges that you talked about with regards to telling patients about these particular options that they have, and then the hope that they might get that something works, and just I wondered if you could talk us through what maybe the guidelines are for that, or how you approach those kinds of situations.
Well, I think having something like INOVATe, so in the traditional way of looking at it, a clinical trial comes up that may, for instance, need somebody with amplified cyclin E. It only occurs in about 10% of patients. So you have to recruit those patients to the trial, put them through pre-screening, they have to sit around and wait, and then only a very small proportion will go on. Whereas in INOVATe, the patients don't even know. It's all happening in the background, in that they've consented for the testing, consented for the whole process, but we don't even approach them to go onto the trial unless we actually know that they will be suitable for that trial. So I think this process will help that you don't have to go through that whole conversation with patients and get their hopes up and then only to have them dashed.
Yeah, okay. Thank you very much. Anybody else? Okay, thank you.